Hello, this is Ms. Roberts. We are going over Chapter 19 today, talking about a child with an endocrine or metabolic condition. It starts on page 633 in your book. On page 634, let's go there. It's discussing the optimizing outcomes. It talks about the general and specific diabetes, stress, and glycemic control, and how the self-management is very important. It also talks about adolescence, so winks and lollipops. Adolescents are required to be taught self-management skills, okay? Very important that they know how to self-manage, how to check their sugar, especially with type 1 diabetes that usually is diagnosed in childhood. Higher general and diabetes specific stress was significantly associated with a higher hemoglobin A1C. Important to know. So the stress does cause sugars to go up. We know that, right? Healthcare providers must be mindful. The sources of stress that adolescents face have a direct effect on their type 1 diabetes, okay? They are, again, a wink and lollipop. They are in that stage where they're trying to figure out who they are and what they want to be, and very mirror driven to see, make sure they're perfect in the mirror. They want to be similar to their peers. They want to be the cool kids. So just very important. And sometimes they don't stop to take care of themselves with diabetes. So they kind of get sidetracked and trying to be the popular kid or the cool kid to keep up with their societal friends. So you just have to remind them to take care of themselves. Over here is a picture of the male endocrine system and the female endocrine system, and what's the main difference. So the testes and the ovaries, right? Everything else is pretty much the same, but those parts of the endocrine system do differ, of course. Your book goes through hormones and their functions. There's some more pictures. But on table 19.1, just some hormones and what their functions are, where they're stored. So just make sure you read through that. On page 639, we're going to talk about growth hormones and their deficiency. Let's go back up to here. This is treatable, of course. There's some conditions. The growth hormone deficient. Turner syndrome is one. Prader-Willi is another. So just be familiar with those names. Let's see. I think it's actually above this chart. Yeah, right here. So, Turner syndrome happens in females. Be the web-necked, some heart conditions, like a shorter stature. So just make sure you read through that. And there's the body systems in that table. The growth hormones, though. So the releasing hormones, of course, everything starts with the hypothalamus. And you have the growth hormone releasing hormone, and then the growth hormone, and then an insulin-like growth factor. So you can look at that and how it metabolizes through the liver, the ghrelins involved, goes through to the stomach, adipose tissue, and then, of course, bone marrow and the long bones. So just a really good picture to explain that. It directly affects then the adipose tissue, and then indirectly affects the bones through the liver. So this is a picture of somebody that's taking growth hormones, not necessarily the legal type, but this is a before and an after picture. So before and then after, okay? Big difference, right? All right. Let's go back up here. And just read through all of these and how the proper growth assessment is assessed, okay? What should be happening at the correct times. And then table 19.3 is talking about laboratory tests for the endocrine conditions. Make sure you read through those. Let's look on page 647. So collaborative care. All right. So just assisting the goals of the child to reach their normal growth rate is important. Another wink and a lollipop. Parents need to be taught about growth hormone replacement therapy. Wink and lollipop. These are given at night because, of course, during sleep, that's when our growth happens the most, right? So we're given those growth hormones. They're usually sub-Q injections every day, but you need to educate those parents the symptoms to watch for. And these are some adverse symptoms here, so just make sure that they're educated in knowing that. And they are given at night, wink and lollipop, okay? This is dwarfism, growth hormone deficiency in a normal child. So dwarfism is just a true deficiency in that growth hormone. It affects 1 in 10,000 children. And there's the side effects of the medications listed that are in your book. On page 650, let's look at that clinical judgment alert. So here, dehydration. Their pulse may be thready. If it's severe dehydration, just make sure you read through that. And then, of course, hypotension with hypovolemic shock. Hypothyroidism and Graves' disease is in your book. I don't spend a whole lot of time on that because you get that in Med-Surg. Addison's disease is in there. Adrenal insufficiency is on page 660. We'll go there. Talking about the adrenal insufficiency. And Cushing's syndrome. On page 662, let's get there. It's discussing the congenital adrenal hyperplasia. It's the lack of the ability to produce cortisol. Okay, so let me find it here. So just make sure you understand that term. That's what that is, congenital adrenal hyperplasia. They cannot produce cortisol, and it can affect their growth. Hyperaldosteronism is on page 664. So just make sure you read through those signs and symptoms. And now we're going to talk about metabolic conditions on page 665. Okay, it's where we focus a lot in this chapter. Type 1 diabetes mellitus. Most common chronic disease of childhood, okay? So if you remember studying diabetes before, it's often caused from destruction of the islets of Langerhans, okay? This is where the insulin is produced in the beta cells, okay? You need to know the difference between type 1 and type 2, okay? So type 1 is cell destruction of those insulin cells, okay? Those beta cells, the islets of Langerhans. And type 2 is insulin resistance, okay? So type 1, they do not produce it. Type 1, it is resisted. So the body fails to recognize it and use it properly. Diagnosis, another winking lollipop. So our number one cardinal sign of diabetes is polyuria. We have the triad, but polyuria is our cardinal sign, okay? Polyuria. They constantly urinating. And this is a good picture. This is just a little girl checking her sugar, and a good picture of the mechanism of insulin, okay? Some signs and symptoms of children with diabetes, not unlike adults, but they have increased thirst and urination, polyuria, right? Slow healing of sores, dry mouth, blurred vision, numbness and tingling from that neuropathy in the hands and feet, unexplained abdominal pain. So what parents can do. So there's a list here. Prevent weight gain, get them regular checkups, maintain optimum vitamin D, stay away from processed foods, soft drinks, keep them active lifestyle. But this is just how the glucose channels, they lock in. So this is the key. Kind of plugs it in. If it works correctly, that insulin plugs in when the glucose plugs in. But when it's closed, it's not working correctly. And then insulin injection site, okay? So we don't pinch up the whole muscle because we give it what? Subcutaneous. So we want it here in this section of the skin, not pulling up the entire muscle because it's not intramuscular, it's subcutaneous. So we're going to look at the assessment tools here. Some more winks and lollipops. So hypoglycemia, assessing the person for low blood sugar. You may see some more shakiness, hand tremors as that sugar drops, some tachycardia, pounding heartbeat, palpitations, important winks and lollipops, okay? And then the growth and development, okay? Let them, as children developing, right, you got to teach them how to check their sugar. You got to teach them about receiving the insulin injections, okay? Play therapy, works well with kids, right? So give them a needleless syringe and give them a baby doll and let them practice giving their baby doll a shot. And that would make them feel more comfortable, just kind of practicing on the baby doll. And then for adolescents, peer group. We talked about this earlier. Peer group and acceptance, body image acceptance is very important. Important issues, okay? And I'll tell you a story about that in class, but with a child that I was on a trip with, and she was a diabetic, insulin dependent, insulin pump, everything. So, all right, let's look on page 669. And there's the pictures that we just talked about in the book. A child giving themselves the insulin injection. Some things that we talked about under the assessment tools. And then this is on page 668, these charts. Hypoglycemia and hyperglycemia. And then on page 669, it talks about the different types of insulin. You should know these already. Humalog, regular, that's fast acting. Intermediates are NPH and Ultralente, and then Lantus. is our long-acting, okay? And then we have our pre-mixed. And I know y'all checked off on this. That you should mix cloudy over clear or clear over cloudy. You tell me. All right. 669. Underneath the picture in your book, it's talking about the different types of insulin again. And this is why we do mix those, because it's better for the child to be stuck once instead of multiple injections, right? Let's see, this is the Lente NPH regular and NPH Humalog are pre-mixed, so we just want to stick them one time instead of several times, okay? Here, right here. So another Waking Lollipop. So let's talk about the steps when you're mixing them. Some of them do come pre-mixed, but you'll mix from the 2 bottles. So of course, you're going to roll that cloudy insulin between your hands, right, to make sure all the powder is dissolved and mixed. You don't shake an insulin bottle. You draw the air into the syringe for the cloudy and then force it into the cloudy bottle, and then you draw the air and draw it to clear. So it's cloudy and then clear, okay? Alright, so make sure that you're giving the child the benefit of more than one type of insulin with one single injection, okay? Winking Lollipop here. Alright. This is a picture that's in your book as well. On page 670, it's of an insulin pump on the back of his arm. Convenient way to make sure they're getting that basal dose, right? All right, page 672. There's that same picture. These are the different spots that they can get the insulin in, of course, and teaching themselves that. All right, so a big thing is making sure that child is supported, making sure that the lines of communication must be kept open to best serve the child and the family. Okay, very, very important. I'm sorry, y'all, I'm trying to find it in the book. It's at the top of 672 on the right side. Okay, so lines of communication must be kept open. I found it. So parents are scared of letting their child with diabetes participate in activities sometimes until they get used to that diagnosis. The Winking Lollipop, listen to what I'm saying. It's important to talk about how the parents are feeling. You know, tell me more about how you're feeling about your son's activities, you know, or your daughter's activities. So keep that line of communication open, and I promise you that's going to be better for the child in the long run. Okay. All right, so let's look at some more signs and symptoms. So Winking Lollipop, fatigue, right? Lethargy, that's a big one. And then our cardinal sign, again, is what? Polyuria. Our cardinal sign of diabetes mellitus. And then our, let's see what page that's on. Page 673, of course, right here, is our plasma blood glucose, what we want it to be, okay? And you can see the A1Cs over here too. And that is it. On page 6, one more thing, on page 677 is, of course, a case study that you should be doing, all right, to put it all together. And that's it for chapter 19.